Well, at the moment, we just buy the individual components priced at the average price, and there's no real assessment of whether we're buying either the right thing or the thing is done right. So I think people are trying to shift their payment design systems to buy what looks like value to the patient, but also what looks like value at a population health level. So rather than just buying individual components, people try and look at the entire product, if you like. So first of all, we have to focus on what the patient needs as a complete package of care. So there's an example in Oldham, for example, where musculoskeletal services are being provided by a single provider acting as a lead contractor. They employ some of their own staff, they use others, but they're taking full responsibility for the delivery of the outcomes to patients. This is one way of doing it. The other way is that the payer has to try in some way stitch that together. That's harder for them to do. In Massachusetts, we're seeing a model in which a contract is set by the payer and asking groups of doctors to come together to generate high quality outcomes for patients. So the real key here is how we're going to do the measurement, because historically it's been very difficult to do outcome measurement, and we are short of quite a lot of the indicators that we need, and we're going to have to do quite a bit of work if we're just not going to ask the patients, did they have a good experience, and are they feeling better? So we use payment currencies to decide what's the best way of paying for hospitals or outpatient care, and it's a sort of just a technical definition of what the component is. The difficulty is that each individual currency in the way we do it is just a component of the care. We are almost buying products by selecting individual pieces rather than defining this is what good looks like for the whole outcome for the patient. So the currency is a necessary condition. Having a good currency is a necessary condition for being able to buy better value healthcare. But actually what you really need to be able to do is to say, for the patient, for the population, what's the proper outcome. The currencies just allow the contractors, the providers and individual clinicians to have some way of exchanging, this is what I did, would you please pay me for it. It's not as essential as this bigger vision about what it is you're trying to achieve. Well, almost every country in Europe is experimenting with some sort of DRG payment system, and the scope of these seems to be expanding as people find out new ways of applying them. That people are developing, in some countries, payment for performance measures, which are sort of micro incentives to encourage people to adopt best practice. I'm not sure that isn't a bit of a dead end. Perhaps a better development is the idea that rather this value-based purchasing idea, which is to say, what does a good outcome look like, and can we buy the whole of that outcome, or could we buy capitation population health management? People are starting to experiment with variants of these, with the DRG payment system just being a way of getting the exchange between the different providers worked out. So, but we're still at an early stage, and at the moment the DRG systems just apply to hospitals, maybe to outpatient care. They're not in mental health, they're not in home care services, and they're only providing funding for a certain amount of hospital activity. So it's easy to overstate just where we're up to on this. It's really, we're in the foothills of learning about how to pay for healthcare still. There's probably less other countries and more there are individual innovations within countries. I mentioned the Blue Cross Blue Shield Massachusetts alternative quality contract. Blue Cross Blue Shield Michigan have an interesting method for encouraging group practice. The French have been trying to incentivise doctors to work together. There's the Dutch have been working on trying to bundle up different payment mechanisms. So I think one has to sort of go very selectively and look at what's been happening. But perhaps the biggest lesson in all of this is that this sort of health policy tourism, without a real deep understanding of the context from which you're borrowing and the institutions they've got and where their starting point, can be a bit of can lead you in the wrong direction. You have to be very careful.